Welcome to the Hospital Medicine Unplugged podcast. Today, we're doing a focused, intensive deep dive into a really critical area for hospitalists.
Yeah.
The evidence-based management of gout in the hospitalized patient.
Right. And our mission here, it's kind of twofold, and it gets complicated, by the inpatient setting itself. We really need to synthesize the current evidence. We're talking NDJM, JAMA, ACP, and ACR guidelines to tackle that acute, often just agonizing flare. But also, crucially, use that hospital stay as a leverage point, a time to initiate or maybe optimize long-term urate-lowering therapy.
And that inpatient context you mentioned, that's exactly where things often get messy, isn't it? We're not usually dealing with just a simple, isolated case of podagra. Our hospitalized patients, they come in loaded with complex comorbidities, advanced chronic kidney disease, severe heart failure, maybe brittle, poorly controlled diabetes.
Exactly. And those comorbidities, they dramatically narrow our options for just managing the acute pain, and they also make starting long-term therapy, well, frankly, a higher risk situation. The evidence really does suggest that hospitalized patients with gout often get suboptimal care. So this deep dive feels pretty essential for, optimizing how we manage them.
Okay, so let's start right at the beginning. The foundation, the clinical picture, and the pathophysiology of gout itself.
Okay, so fundamentally, it's an inflammatory arthritis. It's caused by the deposition of monosodium urate MSU crystals. These deposit in the synovial fluid and sometimes in soft tissues too. And this crystallization happens purely because of sustained hyperuricemia.
Right, and let's put a number on that. Hyperuricemia is defined as serum urate going over the solubility threshold. That number is usually cited as 6.8 milligrams per deciliter. Anything above that, you risk supersaturation and, well, eventually those crystals precipitating out.
And the clinical importance, especially in the hospital, is huge. We can't really overstate it. Our sources, they repeatedly stress how common gout is and how tightly it's linked with major comorbidities. We're talking renal impairment, cardiovascular disease, metabolic syndrome, the whole picture.
Yeah, and it's interesting, hospitalizations specifically for gout have actually gone up over the last decade or so.
They have. And that often reflects, more advanced disease or maybe significant issues with suboptimal outpatient control that's just kind of spiraled.
So when we see these patients, say, on consult, we recognize there's a spectrum. The most common thing bringing them in is that acute gout flare. It's sudden, it's severely painful, usually affects one or maybe a few joints.
Monoarticular or oligoarticular.
Right. And the classic site, of course, is podagra, that first metatarsophalangeal joint. But the hospital environment itself, that can be a major trigger, can it?
Oh, absolutely. The stress of just being sick, the hemodynamic shifts maybe after surgery, or even just routine medication changes we make. Things like diuretics, for instance. They can acutely destabilize serum urate levels and just kick off a flare.
And then there are the more advanced stages we sometimes see.
Right. You mean chronic tophaceous gout. That implies persistent inflammation, often involving multiple joints, polyarticular involvement, and, crucially, the presence of tophi. Those are those firm subcutaneous nodules, basically packed deposits of urate crystals.
And recognizing that tophaceous gout is really important, isn't it? Because it signals long-standing, probably severely undertreated disease, and it definitely changes the urgency and the aggressiveness we need when thinking about urate-lowering therapy.
Definitely. So let's peel back the layers on a core mechanism. Why do these crystals deposit? Typically, it's driven by reduced renal excretion of urate, which, as you said, is common because of our patients' comorbidities, heart failure, kidney disease, or sometimes ironically because of common meds we use like loop diuretics or even low-dose aspirin for cardioprotection.
Right, so the crystals are there. What happens next?
Okay, so once those crystals are present in the joint space, they're seen as a danger signal. They get phagocytosed, eaten up by resident macrophages there. And this is where the kind of cutting-edge immunology kicks in. That phagocytosis activates something called the NLRP3 inflammasome.
That's like the molecular ignition switch then.
Exactly. That's the trigger. And activating that inflammasome drives this massive release of a key inflammatory cytokine, interleukin-1 beta, or IL-1 beta.
IL-1 beta. That's the real driver of the inflammation we see clinically.
That's the main player. It's the release of IL-1 beta that fuels that huge neutrophil-driven inflammatory response. That's what causes the characteristic just intense pain and swelling of a gout flare. And like we were saying, the hospital stay itself, fluid shifts, being immobile, changes in diet, starting a new drug that affects fluid balance. Any of that can shift urate levels just enough.
To tip them over the edge.
Exactly. Tip them into a flare, activating that whole IL-1 beta cascade we just talked about.
Okay, so understanding that mechanism, that detailed pathophysiology, It really leads us logically to the next critical step. We've set the foundation, but before we even think about treatment, getting the diagnosis right is, well, it's a major potential pitfall in the hospital setting.
Absolutely. Let's talk about that ruling out the dangerous mimics.
This is just paramount. I mean, the single biggest, most dangerous mistake any of us can make is treating gout empirically without a definitive diagnosis, especially when you've got septic arthritis potentially lurking there as a mimic. That's terrifying.
It is, and the NEJM review is crystal clear on this. Diagnostic confirmation, ideally, should come from aspirating the affected joint, or maybe a tophus if one is present and accessible. Identifying those needle-shaped, negatively birefringent monosodium urate crystals under polarized light microscopy that gives you 100% specificity, it's still the gold standard.
And the critical action point for every hospitalist, and this is backed up by ACP guidelines too, is that joint aspiration is essential. Essential to rule out septic arthritis or even pseudogout, especially if the presentation is atypical, maybe polyarticular, or if the patient is febrile. We just cannot afford to miss an infection.
Totally agree. But let's acknowledge the reality. Sometimes aspiration is tough. Maybe the patient has multiple joints involved, or they're critically ill, or perhaps they're on therapeutic anticoagulation, or the joint itself is just anatomically challenging. Think about the hip or the shoulder. Aspiration isn't always easy or even possible.
That's a really vital point. And do the guidelines acknowledge that clinical complexity?
They do. They recognize it. If joint aspiration genuinely isn't feasible, maybe it's technically too difficult, or there's a strong contraindication, the ACP does support using validated clinical algorithms. These are based on a classic history and physical exam findings. Things like the ACRE-ULAR classification criteria, for instance. They show pretty good sensitivity and specificity, often over 80% for classic presentations.
So those are validated tools we can use for some clinical assurance.
Yes, and this is a big, but they should never replace aspiration if infection is seriously on your differential diagnosis. Never.
Okay, that makes sense. Now, what about serum urate levels? It feels like that test gets ordered all the time in the acute setting, but our sources seem pretty strongly cautionary about relying on it for acute diagnosis. Why is that?
Yeah, it's ordered constantly, but it has extremely limited diagnostic value during an acute flare. The levels can actually be normal or sometimes even deceptively low.
Low? Why low?
Well, partly because the inflammatory surge itself can cause a temporary increase in urate clearance by the kidneys, or simply because the urate has already precipitated out of the serum and is now sitting as crystals within the joint fluid. So while it's true that almost all inpatient flares happen in people who have underlying hyperuricemia, a baseline level above 6, the number you get during the acute flare itself shouldn't be used to confirm or rule out gout.
Got it. So serum urate during a flare, not helpful diagnostically. What about imaging beyond plain x-rays, things like dual energy CT or musculoskeletal ultrasound, looking for that double contour sign?
They exist, and they can be helpful sometimes. Dual energy CT, or DECT, can actually visualize urate deposits. Ultrasound can show the double contour sign, which is urate crystals coating the cartilage. They might be considered if there's still persistent diagnostic uncertainty after clinical assessment, and maybe aspiration wasn't possible or wasn't definitive.
But are they recommended for routine use in the acute setting?
No, definitely not routinely recommended. Their main role is really when the clinical picture is still muddy and aspiration hasn't clarified things. But you have to remember the principle of speed, especially when infection is possible. Waiting around for a CT scan slot or getting an ultrasound read when you're worried about septic arthritis, that just adds unnecessary, potentially dangerous delay.
Right. So aspiration remains the fastest, most specific, highest yield test for us as hospitalists. Okay. So let's say we have our confirmed diagnosis. Ideally, we've seen those MSU crystals. Now we can move on to managing the acute gout flare in the hospital. The general principles seem pretty clear. Rapid pain control, get function back, and really importantly, tailor the therapy based on the patient's specific comorbidities and contraindications. And start therapy fast, right? As soon as possible after the flare starts.
Absolutely. Prompt treatment is key. And the ACP guidelines are firm here. They recommend monotherapy initially, using one of the 3 main first-line options. That's KOK-cycine, NSAIDs, or systemic glucocorticoids. But choosing which one, that's where it becomes, as you said, a minefield defined entirely by the patient's underlying health issues.
Okay, let's break those down. Let's start with KOK-cycine. I think many of us remember the older, high-dose regimens that inevitably led to, well, significant GI distress.
Oh yeah, terrible diarrhea and cramping. predictable toxicity. But the guidelines have fundamentally shifted on this, based on good evidence showing that efficacy is achieved at much lower, much less toxic doses.
So what's the recommended low-dose regimen now?
The preferred approach is 1.0 to 1.2 milligrams initially. So 2 of the 0.6 milligram tablets, typically, followed by 0.5 or 0.6 milligrams, just one tablet about an hour later. That's all on day 1. After that, it's just 0.5 or 0.6 milligrams once or twice daily for about 7 to 10 days. The crucial point is the total dose on day 1 is usually just 1.8 milligrams, and subsequent daily doses are low. This maximizes the anti-inflammatory effect while really minimizing those GI side effects.
Okay, that's much more tolerable, but the contraindications and interactions with KOK-cysteine, that seems like the really complex part, especially in our hospitalized patients who are often on multiple medications.
It is. This is probably the trickiest one for interactions. You absolutely must avoid KOK-cysteine in severe renal impairment, say a GFR less than 30 or severe hepatic impairment. But maybe more insidiously, you have to avoid it or use it with extreme caution and dose reduction if the patient is taking strong inhibitors of CYP3A4 or P-glycoprotein.
And that's where the clinical trap lies, right? Because common inpatient meds fall into that category.
Exactly. Think about drugs like clarithromycin, some azole antifungals, even certain cardiovascular drugs like verapamil, diltiazem, amiodarone, or even dujoxin. These drugs can significantly boost KOK-cysteine levels in the blood, potentially leading to really serious, life-threatening neuromuscular toxicity like rhabdomyolysis or hematologic toxicity. So, rigorous medication reconciliation, checking specifically for these interactions, is absolutely mandatory before you even think about giving KOK-cysteine.
Okay, so KOK-cysteine requires careful screening. What if it's out? Many people might then instinctively reach for NSAIDs. They work well for inflammation.
They are effective anti-inflammatories, yes. But given the typical profile of our hospitalized gout patients, NSAIDs should honestly be avoided in the vast majority of cases we see on the wards.
Why so strict?
Because the average patient having an inpatient gout flare often has significant kidney dysfunction, maybe advanced CKD or severe cardiovascular disease, or perhaps uncompensated heart failure. And NSAIDs are just notorious for causing acute kidney injury, worsening fluid retention, which is bad in heart failure, and interfering with blood pressure control. So in our typical hospitalized population, NSAIDs are frequently the most harmful option available, even though they work for the joint pain.
Okay, that's a strong caution. So if KOK-cysteine is out due to interactions or kidney function, and NSAIDs are usually out due to kidney or heart issues, that often leaves us with systemic glucocorticoids. They seem to be the workhorse.
They often are. They're frequently the go-to. The standard recommendation is typically prednisone, usually around 0.5 milligrams per kilogram per day. You can give it orally or intravenously, and then typically taper it over maybe 7 to 10 days.
And their advantage is they sidestep some of the renal and cardiovascular issues.
Exactly. Glucocorticoids offer high efficacy and are often the safest systemic choice when kidney problems or heart disease rule out KOK-cysteine or NSAIDs. But of course, they have their own set of inpatient constraints. We have to avoid them or use them very cautiously in patients with poorly controlled diabetes because they'll likely cause significant hyperglycemia. And obviously, you can't use them if the patient has an active uncontrolled infection. We don't want to trade resolving joint pain for causing a systemic catastrophe like sepsis or a hyperglycemic crisis.
Right. So careful patient selection again. Now, what if systemic therapy is just completely contraindicated? Maybe you have a patient with really severe heart failure and brittle diabetes and maybe kidney disease. What then?
That's where intra-articular glucocorticoids become incredibly valuable. If the patient has just 1 or maybe 2 joints-involved articular disease, and you can safely access the joint.
Assuming you've already ruled out infection with that initial aspiration.
Absolutely, assuming infection is ruled out. Injecting steroids directly into the joint delivers powerful anti-inflammatory action right where it's needed, with minimal systemic absorption and side effects. So when local injection is feasible, it really should be prioritized in those complex patients with multiple contraindications to systemic therapy.
Okay. Now, what about the really tough cases, the ones refractory to these first-line options, or patients who just seem to have contraindications to everything?
Yeah, those are challenging. For patients who are truly intolerant of or just don't respond to KOK, cysteine, NSAIDs, and steroids, or those who have significant combined contraindications, the ACR does conditionally recommend considering interleukin-1 inhibitors. These are biologic agents like anakinra or canakinumab.
These are the more specialized, expensive options.
They are. They're reserved for the truly severe, complex situations. And yes, cost and accessibility are definite issues. But remember, we talked about IL-1 beta being the key driver. These drugs directly block that pathway, so they offer potent and rapid anti-inflammatory effects, and they can be particularly useful when you really need to avoid steroids and NSAIDs. Also, for just getting rapid relief in a truly severe flare, sometimes parenteral glucocorticoids like IV methylprednisolone might offer the quickest initial turnaround, acting as a bridge until maybe an oral steroid taper or another agent can take over.
Okay. But before we move off acute management, there's one crucial rule we need to hammer home, right? Regarding urate-lowering therapy during the flare.
Yes, absolutely critical. Regardless of which anti-inflammatory you choose, KOK, cysteines, steroids, NSAIDs, if you must, you should avoid initiating or escalating urate-lowering therapy, ULT, during the acute flare itself. The immediate focus has to be on controlling the inflammation first. Starting or increasing ULT right then can paradoxically worsen or prolong the flare in the short term. Let the fire cool down first.
Okay. Control the fire first, then address the fuel source later. That makes sense. And that brings us nicely into the next logical phase, optimizing the chronic gout management and ULT. As we said at the start, the hospitalization is this critical but often missed opportunity. If we only treat the acute pain and send the patient out without addressing the underlying hyperuricemia, we've kind of failed them, haven't we?
We really have. It's a huge missed opportunity. We have to use this moment to either initiate ULT if they're not on it and meet criteria, or optimize their existing regimen if it's clearly not working.
And who needs ULT? What are the main indications according to the ACR?
The ACR is quite clear. ULT initiation or optimization is recommended for patients who have recurrent flares, and they define that as 2 or more flares per year. Or if the patient has any tophi present on exam, or if there's evidence of radiographic damage, erosive joint disease due to gout. Honestly, if someone is admitted to the hospital with a gout flare, they almost certainly meet at least one of those criteria.
Right. So most hospitalized patients with a flare should probably be considered for ULT initiation or adjustment. And the strategy isn't just prescribing a pill, it's about a specific approach, right?
Exactly. The foundational strategy here is the treat-to-target approach. We're not just giving a fixed dose of a drug. We're actively titrating that therapy, adjusting the dose based on regular monitoring to reach a specific goal.
And what is that goal? What's the target?
The goal, which is pretty much non-negotiable according to guidelines, is to titrate the ULT dose to achieve and then maintain a serum urate level below 6.0 milligrams per deciliter. That's the key number, below 6.0.
Below 6.0. Okay, is it ever lower?
Well, for patients who have really advanced disease, particularly those with visible tophi, some guidelines actually advocate for an even more aggressive target, maybe below 5.0 milligrams per deciliter. The thinking there is that a lower target might help dissolve those existing crystals and tophi faster. But for most patients, achieving and staying below 6.0 is the standard metric for long-term success and preventing future flares. All right, so treat to target, aiming for less than 6.0. What's the first-line drug for ULT? Allopurinol. It remains the preferred first-line ULT agent. It's effective, it's generally well-tolerated, and it's inexpensive.
And how do we start it, especially in the hospital or planning for discharge?
You need to start cautiously. Initiate at a low dose. The usual recommendation is less than or equal to 100 milligrams daily, and potentially even lower, maybe 50 milligrams daily, in patients who have significant chronic kidney disease, say stage 4 or 5 CKD. Then the crucial part is you need to titrate it upwards.
Okay, let's pause on that titration, especially in CKD patients, because for years there was this dogma, right, that you had to dose restrict allopurinol based strictly on creatinine clearance.
Oh, absolutely. That was the old way, the renal dosing approach.
Yeah.
And the consequence was that a huge number of patients, particularly those with CKD, never actually reached the target urate level. They remained persistently hyperuricemic, often on suboptimal doses like 100 or 200 milligrams a day, and they just kept having flares.
But that thinking has changed now based on newer evidence.
It really has. Recent, high-quality evidence, which is strongly reflected in the latest ACR guidelines, has shifted this paradigm significantly. The ACR now emphasizes that allopurinol can and in fact should be safely titrated above those traditional GFR-based dose limits, even in patients with moderate to severe CKD.
Wow, so that's a major shift in practice for many of us. We're moving away from that fixed dosing based on GFR.
And moving towards a purely target-driven approach. The dose you need is the dose that gets the patient's serum urate below 6.0, regardless of their GFR, within reason and with appropriate safety checks. But, and this is important, this titration must be done gradually. You typically increase the dose slowly, maybe every 3 to 6 weeks, not daily or weekly. And it requires very close monitoring of the serum urate level to guide the titration and ensure you're hitting that target safely.
Okay, gradual titration, guided by serum urate levels, aiming for less than 6.0, even in CKD. Now, with that more aggressive titration, what about safety? Specifically, the risk of allopurinol hypersensitivity syndrome, or AHS.
That's a critical safety consideration, especially since AHS can be fatal. The ACR now recommends quite strongly screening for a specific genetic marker, HLA-B star 5801, before starting allopurinol in certain populations. This screening is recommended for all patients of Asian descent, like Han Chinese, Korean, Thai, and should be considered for Black patients as well. Why? Because carrying this HLA-B 5801 allele dramatically increases the risk of developing AHS. Screening helps us identify those high-risk individuals beforehand.
And this is especially important in patients with CKD who already have a higher background risk for AHS.
Exactly. The risk is higher in CKD, so screening becomes even more crucial in those specific ethnic groups if they also have kidney disease. It's a required safety step before initiating allopurinol in those populations according to the guidelines.
Okay, so start low, titrate gradually to target less than 6.0, screen high-risk populations for HLA-B 5801. Now, another key element that often gets missed, especially at discharge, is prophylaxis, right? You mentioned starting ULT can paradoxically trigger a flare.
Yes, this is absolutely essential and often forgotten. When you start allopurinol, or even when you increase the dose during titration, you can actually increase the risk of an acute flare in the short term. It's thought this might be due to the rapid change in serum urate levels, destabilizing existing crystal deposits.
So how do we prevent those flares during initiation or titration?
With anti-inflammatory prophylaxis, it's considered mandatory during allopurinol initiation and during dose adjustments. The recommended agent for prophylaxis is, again, low-dose Colchicine, typically 0.5 or 0.6 milligrams once daily. Low-dose prednisone is an alternative if Colchicine is contraindicated. The rationale is to keep the joint inflammation suppressed while the urate level is gradually being lowered by the allopurinol.
And how long does this prophylaxis need to continue? That seems like another area where things can go wrong if stopped too soon.
It is. Stopping prophylaxis prematurely is a common reason for treatment failure and early flares, leading to poor adherence. The recommendation is to continue the prophylactic Colchicine, or alternative, for at least 3 to 6 months, or potentially longer, until 2 conditions are met. The serum urate target of less than 6.0 milligrams per deciliter has been achieved, and the patient has been completely flare-free for at least 1 full month. Some say even longer, like 3-6 months flare-free after reaching target. Only then is it generally safe to consider stopping the prophylaxis.
Okay, so prophylaxis is key, and duration matters. 3 to 6 months minimum, and until target urate is hit and they're flare-free. What about alternative ULT agents if someone truly can't take allopurinol? Maybe they had a documented hypersensitivity reaction, or they tested positive for HLA-B 5801.
Febuxostat is the main alternative oral agent. It's a non-purine xanthine oxidase inhibitor, so it works similarly to allopurinol, but has a different chemical structure. It's a reasonable option for patients with true allopurinol intolerance. However, there's a significant caution with febuxostat, particularly in patients with established cardiovascular disease.
Oh, yes, the CARES trial and subsequent concerns.
Exactly. Clinical trial data raised safety signals regarding a potential increase in cardiovascular mortality and major adverse cardiovascular events compared to allopurinol in patients with known CV disease. So while it's an option, caution is definitely advised, and it might not be the preferred choice in someone with significant heart history. You need to have that risk-benefit discussion.
Okay. And then there's this sort of big gun for the really extreme cases.
Right, you're talking about pegloticase. Pegloticase is reserved strictly for patients with severe, often crippling chronic tophus gout that is refractory, meaning unresponsive to maximum doses of oral ULT agents like allopurinol or febuxostat. It's an intravenous medication, a recombinant uricase enzyme. It works by rapidly breaking down uric acid into a more soluble compound. It can lead to really dramatic dissolution of urate crystals and shrinkage of tophi. But it's expensive, requires IV infusions, and carries risks like infusion reactions and antibody formation, so its use needs specialized management, usually by a rheumatologist.
Okay. So clear hierarchy. Allopurinol first, febuxostat as an alternative, with CV caution, and pegloticase for the truly refractory, severe cases. Let's shift gears slightly now and talk about some of the hospital-specific challenges and maybe more sobering, the long-term prognosis if gout is undertreated. Managing those comorbidities we keep mentioning seems inseparable from good gout care.
It really is. You can't manage gout in a vacuum. It's not just a rheumatologic issue. It's deeply intertwined with cardiometabolic health. Hypertension, hyperlipidemia, diabetes, chronic kidney disease, they all travel together. So comprehensive management absolutely requires addressing these comorbidities at the same time. For example, if you're managing a patient's heart failure or hypertension with, say, a thiazide or loop diuretic, you need to recognize that those drugs raise serum urate levels and will likely impact their gout control. You might need to be more aggressive with their ULT.
And that medication reconciliation becomes even more critical in this context.
Absolutely crucial. We talked about the KOK-cysteine interactions with CYP3A4 and P-glycoprotein inhibitors need to meticulously screen for those. But it's also about actively choosing not to use certain drugs, like rigorously avoiding NSAIDs in a patient whose kidney function we're trying desperately to preserve, or being cautious with steroids in someone with poorly controlled diabetes. It's about tailoring the whole regimen.
And beyond medications, the hospitalization itself is a teachable moment, right, for patient education.
A hugely important, often underutilized teachable moment. For many patients, this might be the first time they really start to understand that gout isn't just about occasional painful joints. It's a chronic systemic disease driven by high uric acid. We need to explain the why behind ULT, why they need to take a pill every day, potentially for life, to hit that target of less than 6.0. And importantly, we also need to clarify the role of lifestyle and diet. While helpful adjuncts, we must disabuse them of the myth that simply avoiding purine-rich foods or alcohol alone can control established gout. It can't. ULT is the cornerstone.
Yeah, setting realistic expectations about diet is key. So why does all this aggressive management, hitting the target, educating the patient, why does it matter so much in the long run? What's the prognosis if we don't get this right?
Well, the long-term prognosis of undertreated gout is honestly pretty devastating, and it goes way beyond just having sore joints.
What kind of consequences are we talking about?
If ULT isn't optimized, undertreatment basically guarantees progression of the disease. You get chronic, damaging, erosive arthropathy, leading to significant functional disability. You get progression to chronic tophaceous gout with those disfiguring deposits. But perhaps even more critically, especially for us as hospitalists, are the systemic risks.
The cardiovascular connection again?
Yes. The evidence linking chronic gout and the systemic inflammation that comes with it to cardiovascular risk is really compelling now, and it's growing. Patients with chronic hyperuricemia and gout have an independently increased risk of major cardiovascular events. We're talking heart attacks, MI, stroke, and overall cardiovascular mortality.
Wow. So gout isn't just painful, it's potentially cardiotoxic if left uncontrolled.
That seems to be the implication. Furthermore, chronic gout is also associated with an increased risk of venous thromboembolism, DVT and PE. And looking at the kidneys, untreated gout can accelerate the progression of chronic kidney disease and also increases the risk of developing kidney stones, nephrolithiasis. So you see, gout isn't just a simple joint complaint. It's a marker and likely a mediator of serious long-term systemic disease and significant vascular risk.
Okay, that really underscores the importance of getting control. But there's good news too, right? What's the prognosis if we do manage it effectively with the treat-to-target approach?
The good news is the prognosis is generally very favorable when we successfully implement that treat-to-target strategy. When patients achieve and consistently maintain that serum urate level below 6.0 milligrams per deciliter, the benefits are profound. We see dramatic reductions in the frequency and severity of gout flares. Over time, existing tophi can actually resolve or shrink significantly. And perhaps most importantly for the patient, there's usually a huge improvement in their overall quality of life and function.
So effective treatment works really well.
It does. But conversely, the prognosis remains significantly poor for those patients who remain undertreated, or those who have truly refractory disease that doesn't respond even to aggressive therapy. And this just highlights the urgency of our approach as hospitalists, getting ULT started correctly, ensuring the patient understands the plan, and setting up good follow-up. It's not just about relieving a painful joint today, it's really a public health imperative for cutting down their long-term systemic risks, morbidity, and even mortality.
Okay, that's a powerful message. To try and bring this really comprehensive deep dive together, let's crystallize the key, actionable takeaways for our colleagues listening for practicing hospital medicine. What are the absolute must-dos?
Okay, I think there are 3 critical steps. First, confirm the diagnosis, don't guess. The gold standard is joint aspiration, looking for those MSU crystals that gives you 100% specificity. And critically, rule out septic arthritis immediately, especially in atypical cases. Remember, serum urate during an acute flare is not a reliable diagnostic marker.
Right. Aspirate first, diagnose definitively. What's takeaway number 2?
Second, individualize the acute anti-inflammatory therapy based strictly on the patient's contraindications. Choose your monotherapy low-dose KOK-cycine, systemic glucocorticoids, or maybe NSAIDs in very select low-risk patients based specifically on their comorbidities. Pay meticulous attention to renal function, heart failure status, diabetes control, and especially those potential drug interactions, like with KOK-cycine and the CYP3A4 inhibitors.
Okay. Tailor acute therapy to the patient's risks. And the third key takeaway.
Third, and maybe the most impactful, long-term. Use the hospitalization as that critical opportunity to initiate or optimize ULT. Don't just treat the flare and forget the underlying cause. Start allopurinol low, typically less than or equal to 100 milligrams daily, and crucially, commit to the plan of titrating upwards towards that serum urate target of less than 6.0 milligrams per deciliter. Remember, this treat-to-target approach applies even in patients with CKD, with careful monitoring. And absolutely ensure that mandatory anti-inflammatory prophylaxis, usually with low-dose KOK-cycine, is prescribed for at least 3 to 6 months to prevent those paradoxical flares during titration. And make sure rigorous follow-up is arranged to manage the titration process after discharge.
Confirm diagnosis, individualize acute treatment based on risk, and use the admission to start or fix the long-term ULT with prophylaxis and follow-up. Got it. Now, for a final thought to leave our listeners with, considering the incredibly strong link you described between chronic gout, systemic inflammation, and particularly that increased cardiovascular risk, how should our hospital protocols, maybe even our mindset, evolve? Should we start thinking about mandating gout optimization as a core part of cardiovascular risk reduction for these patients, rather than just treating it as, another painful joint complaint that needs fixing today?
That's a really provocative and important question.
We'd encourage you, the listener, to perhaps explore the literature on this further. Think about the potential role of effective long-term ULT, not just in preventing flares, but in actually mitigating those serious long-term systemic risks. It really makes you consider that treating the joint properly might ultimately be about protecting the heart and the kidneys down the road.